Today, we are going to walk through a complete clinical case presentation of choriocarcinoma, step by step, exactly the way you should think in a real clinical setting or in an exam. This is not just about memorizing facts. This is about developing clinical reasoning, connecting symptoms, investigations, and pathophysiology into a single coherent diagnosis. Let's begin with the patient in front of us. We have a 23-year-old female who presents with a combination of symptoms that, at first glance, may seem unrelated, but when carefully analyzed, form a very characteristic pattern. She comes with complaints of irregular, heavy vaginal bleeding for the past 2 months, which is already a red flag in a reproductive age woman. But this is not just normal, abnormal uterine bleeding. This is persistent, heavy, and progressively worsening. Along with this, she reports lower abdominal pain and a sensation of swelling, suggesting a possible pelvic pathology. But the case becomes more interesting and concerning when she mentions a persistent cough associated with hemoptysis, meaning she is coughing up blood. This immediately raises suspicion for pulmonary involvement, which is unusual in simple gynecological conditions. She also complains of shortness of breath on exertion, along with generalized weakness and fatigue, which could point toward anemia or systemic disease. Now, when we combine gynecological symptoms with respiratory complaints, we must think beyond localized disease. This is where clinical reasoning begins to narrow down possibilities. Let us now explore her past medical history, which provides a crucial clue. She has a history of a complete hydatidiform mole 1 year ago, which was appropriately managed and followed up with serial β-hCG monitoring. Additionally, she had a recent uncomplicated term pregnancy 6 months ago. This history is extremely important because choriocarcinoma is a type of gestational trophoblastic neoplasia, and it can arise after a molar pregnancy, normal pregnancy, miscarriage, or even ectopic pregnancy. So now we have a reproductive age woman with abnormal uterine bleeding, systemic symptoms, lung involvement, and a history of trophoblastic disease. This combination should immediately raise suspicion for choriocarcinoma. Moving on to the general examination findings, we observe that the patient appears pale, indicating anemia, likely due to chronic blood loss. Her pulse is elevated, suggesting tachycardia, and her blood pressure may be on the lower side, reflecting volume depletion or systemic illness. There is no significant lymphadenopathy, and her thyroid examination is normal, which helps rule out other endocrine causes of bleeding. Now let's proceed to the systemic examination, where the diagnosis becomes even clearer. On pelvic examination, the uterus is enlarged, irregular, and soft, which is not typical of a normal postpartum uterus at this stage. We may also detect adnexal masses, which are often theca lutein cysts, commonly associated with high levels of β-hCG. Additionally, there may be vaginal nodules, which represent metastatic deposits, another strong indicator of a malignant process. On lung examination, findings such as reduced air entry or scattered nodules may be present, corresponding to pulmonary metastases. In fact, choriocarcinoma has a strong tendency for hematogenous spread, particularly to the lungs, which explains her cough and hemoptysis. At this stage, even before investigations, we are already highly suspicious of metastatic gestational trophoblastic disease. Now let's understand the pathophysiology, which ties everything together. Choriocarcinoma arises from abnormal proliferation of trophoblastic tissue, specifically cytotrophoblasts and syncytiotrophoblasts, without the formation of normal chorionic villi. This is a key histological feature, absence of villi with malignant trophoblastic cells. These cells are highly invasive and rapidly proliferating. They invade the myometrium and then penetrate blood vessels, leading to vascular invasion. Once inside the bloodstream, they spread hematogenously to distant organs, most commonly the lungs, but also the brain, liver, and vagina. This explains why a uterine origin tumor presents with lung symptoms and systemic manifestations. Another critical feature is that these tumor cells produce very high levels of β-hCG, which becomes a key diagnostic marker. Now let's move to the investigations, which confirm our clinical suspicion. The most important test here is serum β-hCG. In choriocarcinoma, β-hCG levels are markedly elevated, often exceeding 100,000 MIU/ml. Serial monitoring is also important to assess disease progression and response to treatment. Next, we perform a complete blood count, which often shows anemia, consistent with chronic bleeding. A complete metabolic panel helps assess liver and kidney function, especially important before starting chemotherapy. We also check thyroid function tests, because very high β-hCG can cross-react with TSH receptors and cause hyperthyroidism-like symptoms. Imaging plays a crucial role. A transvaginal ultrasound may reveal a heterogeneous uterine mass, along with theca lutein cysts. A chest X-ray or CT scan is essential and may show multiple cannonball pulmonary nodules, which are classic for metastatic choriocarcinoma. Further imaging, such as CT abdomen and pelvis or MRI brain, is done to assess for metastasis to other organs. At this point, with elevated β-hCG, characteristic imaging, and clinical findings, the diagnosis is essentially confirmed. Now let's move to management, which is one of the most important and rewarding aspects of this disease. Despite being highly malignant, choriocarcinoma is highly sensitive to chemotherapy, making it one of the most curable cancers, even in metastatic stages. The first step is risk stratification, usually done using the WHO/FIGO scoring system, which categorizes patients into low-risk and high-risk groups. For low-risk patients, single-agent chemotherapy, typically methotrexate, is sufficient and highly effective. For high-risk patients, combination chemotherapy is used, most commonly the EMACO regimen, which includes etoposide, methotrexate, actinomycin D, cyclophosphamide, and vincristine. In certain situations, surgical intervention may be required. A hysterectomy may be considered in patients who have completed childbearing or in cases of uncontrolled uterine bleeding. Metastasectomy is rarely performed, but may be considered in isolated resistant lesions. One of the most critical aspects of management is monitoring. Patients require serial β-hCG measurements until levels become undetectable, followed by continued monitoring to detect recurrence early. Another key point is contraception. Patients are advised to avoid pregnancy during the follow-up period, as pregnancy can interfere with β-hCG interpretation. Supportive care is also essential. This includes blood transfusions for anemia, psychological support, and multidisciplinary care, involving oncologists, gynecologists, and radiologists. Now let's summarize the clinical reasoning in this case. We started with a young woman presenting with abnormal uterine bleeding. We identified additional systemic symptoms: lung involvement, fatigue, and anemia. We uncovered a crucial history of previous molar pregnancy. We correlated clinical findings with high β-hCG levels and characteristic imaging. And we arrived at the diagnosis of choriocarcinoma with metastasis.